Hi, this is Dr. Bhargava. In this series, I have several interesting cases to share with you. Here's our first patient, a middle-aged female who presented with a CT scan of the abdomen and pelvis, and incidentally, a enhancing mass was seen in the right lower quadrant, right there next to the inguinal canal. And so, what could this be? It could be a tumor. And on the CT, we cannot say much more than that. And so this patient underwent an ultrasound where the technologist thought that this was the right ovary. Since they've labeled it as ovary, the mass that measured about 4 by 2.6 by 3.3 cm, and it's a solid mass with internal vascularity, so that didn't answer the question. This wasn't the patient's right ovary. It's an enhancing mass pretty far from where the ovaries are. So this patient underwent a MRI of the pelvis, and on the top we have T2 weighted small field of view images in all three planes. And this is the sagittal image showing low T2 signal and high internal signal. Here is the mass showing classic T2 hypointensity that we see in a fibroid. It shows contrast enhancement. We know fibroids enhance, and also paying attention to the small structures around it. It seems to be connected to this T2 hypointense fibrous cord. Similarly, there is a cord that goes from the fundus of the uterus on the left side into the inguinal canal, and it will end at the labia. This is the round ligament, and fibroids can arise from the round ligament, and so the mass that we are seeing is a round ligament fibroid. Not very common, but can also be seen in postmenopausal women, and usually they are asymptomatic, but when there are symptoms like mass effect or pain, then they can be removed. This is our next patient. They presented with progressive abdominal distension over a period of months, and the finding is best seen on the coronal image, where we see this large complex cystic mass arising from the pelvis and growing into the abdomen. This mass has fat attenuation, and so that would make it a dermoid cyst or a mature cystic teratoma. It has some peripheral high density components which are tooth inside the dermoid cyst, and also on the axial image we find that there is a second dermoid seen more posteriorly with similar attenuation, macroscopic fat, and a peripheral focus of high density, which is a tooth in a mature cystic teratoma or a dermoid cyst. This is our next patient, and the finding was incidental, but we were happy that we picked it up. On the axial image, we see that this is the penis, and inside the penis we see a catheter and we see a balloon. And on the coronal image, we find that that's where the balloon is. Here is the urinary bladder, so the Foley catheter and the balloon should be inside the urinary bladder. So someone inflated the balloon in the urethra, and we picked it up as an incidental finding on the CT, and we let them know to deflate it, take it out, and put another Foley catheter in the correct position inside the urinary bladder. So once in a while we come across these very important incidental findings that should not be missed on a CT, and so when you do that, then you want to let the providers know that this is what has happened and needs to be corrected. Here's our next patient. They underwent a whole body FDG PET CT to stage their lung cancer. And right away on the rotating image on the left, you can see that they have extensive metastatic disease. Let's take a look at the rotating image. So the lung cancer is on the left side, and we see multifocal hypermetabolic bone metastases. And so here is the tumor in the left upper lobe of the lung, medially located, and we see these multiple foci of increased uptake throughout the bones on this fused coronal PET CT image. Surprisingly enough, these are the images from their CT scan, so this is their primary, and look at the CT chest sagittal image in the bone window, and look at the CT abdomen and pelvis, sagittal image in the bone window. No morphologic abnormalities from the extensive bone mets. And so the teaching point here is that these things can happen. If you see focal hypermetabolism that looks like mets, it is bone mets, but it may be completely negative on CT, like in this patient. This is our next patient, and the findings here are of a tumor in the liver as seen on an MRI, and the findings are classic for a benign tumor. So let's start with the T1 pre-contrast phase, where we see low signal intensity and a central scar. On the arterial phase, we find that there is uniform arterial enhancement peripherally and not in the central scar. And as we go to the more delayed images, we find that the tumor continues to show enhancement. And on the delayed image, the scar also shows enhancement. The scar on T2 weighted image is T2 bright. So putting all of these findings together, we have an arterially enhancing lesion in a non-cirrhotic liver with no washout, a central scar which shows delayed enhancement and is T2 hyperintense. These findings are consistent with an FNH or focal nodular hyperplasia. When the findings are not typical, you may want to repeat the scan using a contrast called EOVIST, and we want to acquire 20-minute delayed images post-contrast in that situation. And if there is enhancement, then it's an FNH. If there is no enhancement, then the finding is most likely an adenoma. So that's how you would differentiate between FNH and adenoma. The other arterially enhancing tumor, which is seen in cirrhotic livers, is an HCC, where there will be uniform arterial phase enhancement, and then on delayed images we will see washout and a pseudocapsule. And in those patients, we use the LIRADS criteria to give it a number from 1 to 4 or 5. Here is another patient, and on their MR, we have an incidental finding in the pancreas. We see a complex cystic lesion, and it shows some septations that we see here. It is attached to the pancreatic duct like we see right there and here. And on the post-contrast images, there is some septal enhancement, but there is no nodular focal enhancement, which would be a suspicious finding which may develop into pancreatic adenocarcinoma. So these findings of a complex cystic focus, which could be in a pattern of bunch of grapes also, with some septational enhancement, but no nodular enhancement and no restricted diffusion, are suggestive of a side branch IPMN or a intraductal papillary mucinous neoplasm. These are images from their MRCP showing the complex cystic mass, attachment to the pancreatic duct, and also the reconstructed image showing the same focus along with other findings that are T2 bright. Here is our next patient. They were diagnosed with prostate cancer. At that time, cancer was localized to the prostate. They received radiation. They did well. Now they're presenting with rising PSA, and we performed a PSMA PET-CT. Let's start by looking at the rotating image. So we see physiologic uptake in the lacrimals, which is characteristic of PSMA PET-CTs. And we see salivary gland activity, excretion from the kidneys into the bladder. Then we see all of this extensive retroperitoneal lymphadenopathy in the abdomen and pelvis with increased uptake consistent with metastatic disease from prostate cancer. The interesting finding is right here. They have a supraclavicular lymph node seen right there on the CT showing intense uptake. And this is called the Virchow's node. And since we have started doing PSMA PET-CTs, we are seeing Virchow's node more often in metastatic prostate cancer patients. Interestingly, there was no focal uptake in their prostate that had previously been irradiated. And they have extensive metastatic disease in the chest, abdomen, and pelvis. This is our next patient. They presented with pain in the right testicle. We performed an ultrasound, and on the ultrasound, we find that there's hyperemia in the right testicle compared to the left. The epididymis is very hyperemic compared to the other side. And what I want to highlight here is whenever a small organ has a disease, inflammation, or tumor, its volume increases. So look at the volume of the right testicle, 18.5 ml compared to the left testicle, about 10 ml. So always look at the volume of the small structures. They will give you an information as to which side is pathologic, because that side will enlarge and its volume will be larger. And so in this patient, because the testis is enlarged, the epididymis enlarged, and also both of them are hyperemic, the diagnosis is right-sided epididymo-orchitis. All right, a MAG3 renal scan in a patient. And so we are looking at the cine. This is in a posterior projection. We see flow to the left kidney, and then we see good function in the left kidney and barely any activity on the right side. So there is no appreciable flow. And as we go to the functional images, there may be some faint activity, but it's not producing any urine, right? So this patient has a non-functioning right kidney. So I looked into their records some time back. They had a functioning kidney, but there was a stone that was passed into the ureter, and it's obstructing right there at the UPJ. That's one of the sites of physiologic narrowing of the ureter. The other two are pelvic brim, where the ureter crosses from the abdomen into the pelvis, and the third site is where it attaches to the bladder, so the UVJ. So those are the three sites of physiologic narrowing of the ureters, and if a stone is passed, it's most likely to be stuck at one of these three sites. So this large stone that measured about a centimeter was stuck at the UPJ, and the urologist tried to help this patient. The stone was removed, but then as a complication of the procedure, they developed a stricture, and the stricture is seen right there. Proximal to the stricture, we see hydronephrosis, and now there is we see hydroureter and hydronephrosis, and there is thinning of the cortex, suggesting that the function has been impaired. And we saw on the MAG3 scan that there is no blood flow or function in that kidney, so it's chronically obstructed, non-functioning kidney as a result of intervention to remove the stone that was obstructing earlier. All right, so this next patient is a female who presented with abdominal pain, and the CT scan showed this complex cystic mass in the pelvis. It is seen right here. And just based on this, we can provide a differential. It could be a tumor, it could be hemorrhage, but we cannot be more specific than that. It's unlikely to be tubo-ovarian abscess, because in that situation, we see thick enhancing wall and a lot of surrounding fat stranding, suggesting inflammation. So the next step is MRI. On MRI, we find that the complex cystic mass shows multiple foci of T1 hyperintensity, suggesting hemorrhage, and we see fluid level, and we know that blood restricts, and so we see high signal on DWI and low signal on ADC images, suggesting restricted diffusion. So putting everything together, this patient has hemorrhagic foci from endometriosis. This is our next patient, and the finding is incidental. Right here at the left side of the abdomen, there is a loop of bowel inside the other. So also seen right there, this is intussusception. Right there on the sagittal image. This intussusception is transient intussusception because proximal bowel loops are not dilated, it's not causing any obstruction, and this is a common finding. If you repeat a CT scan the next day, it would just go away, and so frequently we see transient intussusception as an incidental finding. Usually there is no lead point, such as a submucosal lipoma or a tumor. It's just, as the name suggests, it's transient, and so it will go away, and it happens without a lead point. Here is our next patient, and we performed a multiphasic CT of the liver. So on the top, we have images which are pre-contrast, then we have the arterial phase, portal venous, and delayed images. And the findings here are characteristic of a hepatic abscess. So hepatic abscess are complex cystic masses that show thick enhancing wall, some surrounding hyperemia, and the pus will be hypodense on pre-contrast, arterial, portal venous, and delayed phases. If you did an MRI on this patient, the pus here will show restricted diffusion, so high signal on DWI and low signal on ADC. Here is another image, coronal image, showing the extent of the complex cystic mass, which is an abscess in this patient in occupying most of the liver. So the source of organisms is portal vein, and through the branches of the portal vein that drain the small and the large intestines, organisms get access to the liver, and that's where they colonize and they form an abscess. Rarely this could be hematogenous also in a patient with septicemia. This is our next patient where again we have performed a multiphasic CT of the liver. This patient's liver is cirrhotic. We can see nodular contour, we can see enlarged spleen, and on the arterial phase we see this mass which shows some peripheral enhancement and central hypodensity. And on the delayed phase, the central hypodensity becomes smaller and smaller. And so this is classic for a cholangiocarcinoma. In this patient, we were trying to evaluate for any evidence of HCC in a cirrhotic patient. They also have small volume ascites. So we would give this an LRM for malignancy. It turned out to be a cholangiocarcinoma. This next patient presented with sudden onset of abdominal pain, nausea, and vomiting. We performed a CT of the abdomen and pelvis, and here we see the classic whirlpool sign of dilated and distended small bowel loops. You can see right here, they're sort of in the pattern of a whirlpool around this part in the center where we have the SMA and the SMV. The relationship between SMA and SMV has been reversed, so the SMV is seen on the left, SMA is seen on the right. Also, the swirling of the mesentery is seen right there. Some of the bowel loops show hypo enhancement compared to other normally enhancing bowel loops right there. And on the sagittal image, I'm showing that at the site of the origin of the celiac and the SMA, below that there is no third portion of the duodenum that is crossing from the right to the left, and so that's a sign of malrotation when we do not see the duodenum, C loop of the duodenum go from the right to the left, and this empty space shows that that has not happened, and so for that reason this patient has malrotation and a midgut volvulus leading to this appearance on imaging. Here is another interesting patient. They presented with CT of the abdomen and pelvis. They've had some kind of diversion. So we see colostomy and a parastomal hernia. The history they came in with was a colon cancer or a rectal cancer. And at the side of the rectum, there is this large hypodensity. We also find a metastatic lymph node and hydronephrotic kidneys. On the left side, we find that the cortex is thin, so that means that the function is more impaired compared to the other side where the cortex is preserved. And so the left-sided obstruction is probably more long-standing at the level of the distal ureter, wherever this tumor in the pelvis is. So those are the findings on the CT. And here is our images from their MR showing on the sagittal T2 weighted image a very large complex cystic tumor, a mucinous tumor involving the presacral space. So this was a recurrence in the presacral space for this patient. And more images, the T2 weighted images showing the mucin content of the tumor. Post-contrast images at the bottom showing the more cellular peripheral components of the tumor showing enhancement and the more central mucinous component staying hypo-intense. The cellular septa show restricted diffusion, so high signal on DWI and low signal on ADC. This patient also had a FDG PET CT. Very interesting findings here. Let's start with the rotating image. We see hydronephrosis and hydroureter. So the kidney, where I told you that the function was preserved, is excreting some urine, excreting some FDG into the urine side, seen right there. And on the other side, we see that the function is impaired. And that's the side where we saw that the cortex was thin. Now, at the site of the local recurrence, we see that hypodensity that we saw earlier, and then we see peripheral hypermetabolism. That's where the tumor is in the periphery. It has spread to bilateral inguinal lymph nodes, and also it has invaded into the right ischiorectal space. right there, seen as focal hypermetabolism. So mucinous rectal cancer behaves differently than conventional rectal cancer. It produces mucin, because of which there is less enhancement on anatomic imaging and less hypermetabolism on FDG PET-CT imaging. And we see a similar behavior from metastases also, where there is peripheral hypermetabolism, which could be mild, and central hypodensity because of the mucin. So more images on the same patient. That's the lymph node, and here I'm showing you hydronephrosis, left side worse than the right. This is our next patient, and this is an incidental, interesting finding in a patient with history of prostate cancer. And we're looking at gallium-68, PSMA, PET-CT. There is no evidence of local recurrence or metastatic disease, but there is a focus that is seen in the penis, and this focus is linear, and it shows faint uptake, and this focus corresponds to the corpus spongiosum, or the urethra in the corpus spongiosum, seen right there. So there can be stasis of urine, and if that urine has excreted radiopharmaceutical, you will see some activity there. But this is mild, this is linear, and doing the anatomical correlation, this is stasis in the penile urethra. All right, next patient had a penile prosthesis. We see the cylinder on the right side and the cylinder on the left side. So proximally they look symmetric, but distally there is an aneurysmal dilatation of the cylinder, and this is one of the complications of penile prosthesis. And these are the other parts of the prosthesis. So cylinder aneurysm is what this is called, and this diagram is showing the different parts where there are cylinders, one each in corpora cavernosa, the reservoir that is placed in the pelvis close to the inguinal canal, and the pump stays in the scrotum. So those are the different parts of a penile prosthesis. And whenever we are doing a CT to evaluate a prosthesis, to look for where the reservoir is and if the tubing is intact or not, and if the cylinders are in place, we want to know what are the different parts, what are they called, and what are their normal locations and appearance on CT or MR. This is our next patient. They presented with a history of GI bleed. We performed a multiphasic scan, the bleeding scan, so non-con, arterial phase, portal venous, and delayed. Pay attention here to the second portion of the duodenum. That looks normal right there. And then here on the arterial phase, we see contrast extravasation. That becomes more intense on slightly more delayed phase. And on the further delayed phase, we see more blood in the duodenum with a fluid level. So this patient is bleeding through a pathology in the duodenum. It turned out to be an ulcer in the second portion of the duodenum that was bleeding and causing a patient symptoms. This is our next patient, and here they presented with right lower quadrant abdominal pain. We see appendix right there, which is distended. There is some minimal fat stranding around it. The findings are not very well seen on the axial image, but on the coronal image, we find an appendicolith. Distal to that, the appendix is dilated and distended. We see that finding right here, right? Appendicolith, and the appendix distal to that is distended and dilated. And so this patient has acute appendicitis. This next patient presented with abdominal pain. We performed a CT of the abdomen and pelvis, and we see this very large mass in the pelvis. This has some fecal material inside, a lot of gas or air, and it seems to be coming off the sigmoid colon. So here is the sigmoid. There is some diverticulosis right there, and then it arises from the sigmoid. And so this patient underwent surgery. This turned out to be contained perforation from diverticulitis, and this low density in the presacral region turned out to be a mucinous rectal cancer. So the rectal cancer was causing obstruction. More proximally, there were more stools and gas in the colon, like we see here, and they had developed diverticulitis, which perforated and caused this large contained collection of fecal material and gas, and that was the cause of their symptoms. That's the end of that series. Thank you for watching.